So each endpoint that we have in cancer in general has several limitations. When we look at progression-free survival, the limitation is that, clinically, what does progression-free survival really mean? It's very difficult to explain to a patient. It's very difficult to find the utility of it. When you also look at how to measure progression-free survival, progression sometimes may not be a black or white. When you look at bone scans are very hard to interpret progression on, and so it may be missed when exactly that point is that a patient has progression. So it's a pretty subjective endpoint. When you look at clinical trials that have incorporated independent radiologic reviews, you get different results in progression-free survival. On the other hand, overall survival is a patient's death. And death is something that you can capture very easily and doesn't have any issues associated with it like progression-free survival does. But when you look at overall survival, that's where it's so hard to prove. First of all, you need large trials and you need a long follow-up, especially in breast cancer, especially in ER-positive breast cancer, and you may not have the luxury to do that. You also cannot control for treatments that the patient received after the trial was over. So if you have a trial in the first or second line setting and the patient receives another 5-6 lines of therapy, you can't control for those other lines. And so finding a certain overall survival difference between arms can be very difficult to do. Other endpoints to look at, response rate. Response rate is something that we used to use a lot and now we don't use as much anymore. But when you look at a patient who has symptoms from metastatic breast cancer, and their symptoms are, for example, shortness of breath because of lung metastases, and you help with your drug improve those lung metastases and improve those symptoms, that response rate is extremely important clinically to that patient because she goes from being symptomatic from her cancer to not being symptomatic or less symptomatic. So very, very powerful endpoint clinically. But again, when you look at how do you assess response rate, it can be subjective as well. When you have clinical trials that have looked at response rate from the investigator versus an independent radiologic reviewer, that response rate differs. Other endpoints are safety. These are toxic drugs. These are patients that can have side effects from their cancer. So you have to make sure that safety of your drug is good. You have to make sure that the toxicities from the drug are not worse from the side effects from the patient's cancer. So those are kind of our endpoints cancer-wise and our endpoints safety-wise. So when you look at eribulin, which is the only chemotherapeutic drug in the third-line setting that has given us overall survival benefit, you want to try to maximize its ability to treat breast cancer. And when you look at combinations with other chemotherapeutic drugs, carboplatin, for example, is a good combination. We did a neoadjuvant trial with it and had really good results. But one of the areas that you want to try to look at is other targeted agents. Immuno-oncology, for example, pairing eribulin with immunotherapeutic agents is powerful. Pairing eribulin with PARP inhibitors may be something to look at as well. The eribulin is an interesting drug because even though we call it a chemotherapeutic drug, it has other mechanisms of action. So it doesn't work purely only as a chemotherapeutic drug. And using that property to combine it with other targeted therapies is going to be key. When looking at how you combine treatments for metastatic breast cancer nowadays, you're looking at combinations of targeted drugs and chemotherapy. The targeted drugs that are mostly being looked at, obviously, a big movement in immuno-oncology, many immunotherapeutic agents that we're pairing now, not just with chemotherapy, but other targeted agents as well, such as PARP inhibitors. And you need to kind of make sure that the combinations make sense. There's some preclinical evidence that combining these two agents together makes sense instead of just doing phase 2 trials just to do phase 2 trials. But in most of these combinations include some sort of chemotherapy, the backbone of chemotherapy. And chemotherapy will be cytotoxic, which may help immunotherapeutic drugs work better, but at the same time, it could be immunosuppressive. So these are all areas that we have to study before we start giving these drugs as standard of care. One of the clinical trials we're looking at, which is going to be presented on Friday, is talazoparib, a new PARP inhibitor. It's a large randomized phase 3 clinical trial. We'll see whether this medication is efficacious in women with BRCA1 or BRCA2 germline mutations. Some of the sessions Thursday afternoon are actually very important, looking at endocrine therapy in women with breast cancer and looking at quality of life and looking at other measures that are, our survivorship measures. How do we help our survivors feel better and do better? Because we have more and more survivors out there. So survivorship research should really be one of the highlights of this meeting.